Hey everyone, I'm your host Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. And welcome everyone to today's Ruby University live class. My name is Adrian Martinez, and as always, I will be your host for today's presentation on the importance of functional laboratory diagnostics. So let's go ahead and jump in.
All right. Good afternoon, everybody. I'm glad to be here and glad to share this information with you. Just to give you a little background real quick myself, I've been in practice 42 years. And of course, the first 12 years of my career, I used the standard testing that most of you have used, the serum and plasma testing. It wasn't until I was introduced to some functional testing that really opened up my eyes as far as how we should look at things from a clinical standpoint. So that's what I'm really going to go through with you today and show you how certain things come into play and how this technology has come forward a lot in the last few years. You all are very familiar with functional laboratory testing. You might not know that until I show you some and you go, oh yeah, I'm very familiar with that test. But of course, the reason why functional testing came about in the last couple of decades is because of looking at these three things. How does the person's genetics or individual lifestyle affect them? How does medications affect them? And we know that, a lot of times when we would tell people to go take a test, we'd say, make sure you do it fasting. And the reason why you would do it fasting, of course, is because if they had taken something within 24 to 48 hours, we would see maybe some elevations in the vitamins or minerals and some other components. Well, the functional testing, of course, came about because we wanted to look back at a longer time frame. And the ones that the technology I'm primarily going to emphasize today is what was developed by Dr. Shive at University of Texas, where he found that the lymphocyte was very correlated with other tissues in the body and how this looked back several months. And once again, like I said, I'm going to talk about some other functional tests first to show you that you have been using some functional tests. You might not just realize it and the basis for that. So when we look at testing, of course, we can look at the serum or plasma testing, which of course, most of you were trained on. I was trained on the same thing. Of course, some people do urinalysis. The problem with urinalysis, as you know, is that one, is it just a spot test of the urine? Is it a 24-hour collection? And of course, there's a lot of controversy on that. And of course, does the person have normal kidney function or not? And how do we know that? And once again, I'm going to show you a couple tests, how we compare kidney function, and one that you may be using a lot, and you might think of another one when we go over this. And then of course, we look at intracellular testing, which has been documented by several people in the last few years. So the big question is, why functional versus static? And once again, the main purpose is what you learned and I learned in school as far as the biochemistry and the cells, and I'm going to show you this in a second. But as you know, and this really shows you the purpose of why we went functional more than we do serum, or we should go functional versus the serum or plasma, because if we're really going to see what a cell is doing, don't we have to look inside the cell? But if you're doing serum or plasma testing, you can see that we extract those cells out of it, and we're just looking at the liquid portion of the blood that remains. So we're just seeing really what vitamin or mineral or some other component is in that liquid. We're not really seeing if it's getting in the cell that we want to address, whether it's the white blood cell or the red blood cell or other cells of the body. So like I was talking to a doctor yesterday, and I mentioned this, and I said, if I told you a patient had an elevated calcium in their blood, would you say, oh, they're taking, calcium supplements, or they're toxic in calcium? No, most of the time you would think, oh, they might have hyperparathyroidism, right? So there's some physiological basis going on that's actually causing that calcium to be in the serum or the plasma, but it's not really telling us what's going on in the cell from a functional usage of that calcium. Is that calcium really being utilized, and so on? So, and then of course you can see the differentiation between the serum and plasma, where the serum does not contain clotting factors and so on. But the point is, we're looking outside the cell. So it's like, if you think of a car, and this is how I explain this to my patients, if you look at the car and you say, okay, I'm going to fill up your tank of gas, but if I block your fuel filter and no gas gets to your engine, who cares how much gas you have, right? And so what you're doing when you're looking at serum or plasma, you're looking at the gas tank. you're not looking at the engine. You're not looking to see if that particular gas is getting to the engine or that nutrient is getting inside the cell actually doing its job. And of course, that's what we want to know, right? We want to know, how is this nutrient, how is this product really helping us from that aspect? So it goes back to the cell structure. When we look at this, and of course, we know and you know that these various structures, these organelles are very important to us. Of course, the mitochondria is an energy pact of our cell, but the cytoplasm, certain things happen in the cytoplasm of the cell as well. And this is why we really go into this and we say, okay, well, let's look at a cell. So all of us, I'm going to bring you back a little bit to your chemistry days and biochemistry days where you learned about glycolysis and how this is important for, of course, carbohydrate metabolism, of course, the Krebs cycle, which the main thing is we want to make ATP, right? But that doesn't occur unless we have these particular steps. And so you can see part of this apparatus or part of this schematic is showing us the glycolysis / the upper part of the cytosol. And then of course, this is the mitochondria where the Krebs cycle occurs. And if you look to the middle right of the screen, you'll see NAD. And of course, NAD is more or less indicating niacin. And then as you go around to different areas, the FAD, the coenzyme A, the pyruvate, up top, the acetyl-CoA, all of those products are dependent upon certain vitamins or minerals. And so once again, like the pyruvate dehydrogenase is highly dependent upon niacin, but it's also highly dependent upon thiamine. So the point is, this is, of course, inside the cell. And this is what we want to achieve. We want to make sure that these pathways are getting more or less functional and we're able to go from one step to the other. And if we don't have a cofactor or the coenzyme, which is involving a mineral or vitamin or amino acid or something like that, then of course these things don't occur. And so the cell dies. So when you're looking outside the cell, you're not really seeing what's happening inside the cell. But yet you were trained that way, I was trained that way. And a lot of people, when they're trained that way, they feel comfortable. And when they feel comfortable with that, they don't want change. And like I said, I was very resistant to change 30 some years ago when I was first introduced to this technology. Then I started to collect more and more data in my office, and I started to correlate clinical situations with this to see how it really was correlating with certain deficiencies and certain pathologies, and if there's connections with certain things from a medication standpoint, or once again, a lifestyle like heavy exercise, or if a person was sedentary and so on. So this is what I want you to kind of keep in mind as we're going through this talk, because this is really what we want to achieve. We want to make sure that these intracellular pathways are being functional, and that's why we talk about a functional test. So let's talk about a functional test that you're all familiar with, but you maybe don't even realize, or maybe you didn't think about it as being a functional test. And this is what I usually introduce to all clinicians, because I say, well, if you really don't believe in that functional test, you're doing functional tests out there that you think are very legit, and yet you don't realize it. So, for several years, we used to use serum glucose, as we all know, to monitor our diabetics. And then, of course, we came about where this particular product back in the 1960s came about the HbA1c, and said, well, this test will tell us what the glucose is doing for the last 3 to 4 months. And once again, we know we're looking at the red blood cell. So it's once again, a marker of intracellular functional test. So this is a test, once again, a functional test that we're looking inside the cell, and it's looking for a longer duration, right? Where the serum glucose is a snapshot. So what's the difference between a serum B12 and an intracellular B12? The same thing. Serum B12, you're looking at a snapshot. And intracellular B12, you're looking at a functional test, because you're looking to see if that B12 or the B vitamin or whatever you're looking at is actually going through those biochemical pathways. Well, this we know, this particular hemoglobin is a minor hemoglobin that actually hooks onto glucose and stays there as long as that red blood cell is alive, right? 90 to slash 120 days, which we've all learned. And this is like the standard, right? Very few of us to this day, we might look for a snapshot of serum glucose just that day to see if a patient's doing. But if we really want to know if a diabetic is being consistent with our therapy, we're not going to look at serum glucose. We're going to say, oh, well, let's pull an A1C every 3 to 4 months. So once again, you are using a functional test, and you might not even know that it was a functional test. So, this is just kind of more or less as outline of the benefits of A1C, and you're probably all, if not all of you, are familiar with this. But the one thing I want to point out, because I see a lot of diabetics in my practice, and as the bottom part of this slide, where people say, okay, well, I'm running a 7 or 7.1 hemoglobin A1C. What does that mean from a serum test? That means that that person's roughly running an average of a 150. Well, the reason why this is important is because when you run above 120 on a consistent basis, you start to damage the small vessels, whether it's the eyes, the kidneys, the extremities, the coronary vessels. And that's why now we move that standard down to 5.6 or some labs 5.7, because we want to get under that 120. So when people say, oh, it's okay to run a 7 to 7.5, no, it's not. I know there's people out there that think it is, and they emphasize that, but if you go and look at physiology and you look at the history of this, this is why we've once again have changed this level from 6.0 to 5.6. I was trained at 6.0. I mean, 40 some years ago, that's what it was. If you had an A1C, at 6.0, you were considered good, but now we want it at 5.6. So once again, this is a functional test. We're looking inside the red blood cell, and of course, the red blood cell survives for anywhere from 90 to 120 days. Serum B12, and then people move to a test called methylmalonic acid. So if any of you have ordered this particular test, the methylmalonic acid, you are performing a functional test. And so say, well, how is that beneficial? Well, you can see here by this particular statement, and this was published in the American Academy of Family Physicians in 2003. So we're looking at 20 years ago. We have known this, and we've even known it before then, but 20 years ago, we have found that 50% of patients with subclinical B12 have normal serum B12. So 50% of patients that come in, it might be diabetic, and they might have neuropathy, and you pull a serum B12 on them, and you say, oh, no, you don't have the neuropathy because B12 is good, so it's not B12 deficiency. Well, you could be wrong, because once again, 50% of the time, they're normal. If that person's on metformin, which causes B12 or folate deficiencies, I can guarantee you that they probably have a B12 deficiency, because when I test these people intracellularly, they almost always have a B12 or folate deficiency, which matches up with the literature. So the point is that this is very important to realize that we're missing out on a lot of our diagnostics because we're looking at a snapshot. This is going to hang around for about 48 to 72 hours as far as the serum vitamin B12 levels. And if a person is taking a B complex or B12 supplement, or they're getting injections of B12, it's going to stay high in the serum. But once again, what is happening in the cell? Is that B12 getting inside the cell? So this is why this functional test known as methylmalonic acid came along, because once again, it shows you through this pathway, and it shows you where B12 is involved in the middle of that schematic there, and how it affects the methylmalonyl-CoA mutase enzyme. And without that, once again, you don't continue to go down, and of course you get changes in the methyl CoA. And then if you look above that, where the propanyl-CoA carboxylase is involved, you can see biotin is involved in that connection there. So here's two nutrients that are involved in this pathway. And once again, this is functional, because if we see a certain byproduct like the methylmalonic acid that elevates or decreases, then we know whether or not B12 is there or it's not. Of course, we see a high MMA if we have signs of B12 deficiency, and we might see, well, of course, we see a normal MMA if, once again, B12 is working or is functional. We're not looking at the content. We're looking at, is it enough, and is it getting inside the cell to go through this pathway to really occur, with this. And so this is once again another functional test. So one, if you've ordered this test in the past, I know you all heard about it, it's a functional test. And the most common one that we talked about already, the HbA1c, is a functional test. So that's been around for, like I said, since the 1960s. So when people talk about functional testing and they start looking at different tissues and associations, and this is kind of showing you a schematic, compares, of course, laboratory animals as well as humans, as far as where vitamin C is. Where is vitamin C primarily contained? And if you look at this, if you look at the cells on the right side of this schematic, where it says, of course, neutrophils, monocytes, lymphocytes, platelets, and red blood cell, if you notice, out of all of those white blood cells, which one has the highest content of vitamin C? The lymphocyte does. And you're going to see that there's some information, independent literature out there showing you that other people have looked at the lymphocyte to see if it's a better test for vitamin C than the serum test. And so once again, it shows you certain importance of vitamin C in different organs, but as far as for blood testing, the lymphocyte has the highest content of vitamin C. And once again, this is one of the reasons why Dr. Shive looked at the lymphocyte when he was doing his research. So it's very, very important. So when people talk about looking at content from a tissue standpoint, you can see the pituitary per volume has a very high content of vitamin C. Of course, people always talk about stress and vitamin C in the adrenal glands, which is true because you can see it does have a high content there. And that's why when people are under a lot of stress, vitamin C levels go down and people start to get sick. It's one of the reasons. Or if people exercise heavily and they're kicking in the so-called fight versus the flight mode, that once again, they have more tendencies to become deficient in vitamin C. And of course, you can see here the lymphocyte, as I mentioned, as far as the cells, that this is the one that has the highest content per white blood cell. Now, even though the neutrophil doesn't have as high content as the lymphocyte does, what I want to emphasize and the importance of it is neutrophil doesn't function efficiently if it doesn't have its vitamin C. You know, if you go back to physiology and histology and all that, one of the things we talk about is when someone gets injured or someone has a bacterial infection, it sends off a signal where the inflammatory cytokines get released, and more or less the alarm system, and draws the neutrophils to that site of injury or bacteria to clean up that area, whether it's an injury or bacteria. And we all know that term is chemotaxis. Well, they've shown that chemotaxis actually decreases if the neutrophil doesn't have adequate vitamin C internally. We're not talking about serum vitamin C, we're talking about intracellular vitamin C of the neutrophil. So even though it's, doesn't have the content or the amount that lymphocyte does, vitamin C intracellularly has an impact on the function of the neutrophil. And one thing we know, going back to kind of the A1C and it's kind of tying things together, if a diabetic is not in good control and they have serum glucose levels that are high, it actually has been shown, or if they have a high A1C, either way, that the vitamin C doesn't get into the white blood cell, especially the neutrophil, efficiently, and the chemotaxis doesn't occur. So this is why you hear people always say, oh yeah, if you're diabetic, you're going to heal slower. Well, one of the reasons why that is yes, there's a neurological component, there's a chemotactic component, and that chemotactic function is highly related to vitamin C. And this is why we give vitamin C. Once again, when people get sick, we're trying to heal tissue, is because we're trying to make this white blood cell more efficient. The problem with the neutrophil, as you all know, even though it's the most abundant of all the white blood cells, all the circulating white blood cells, is that it dies off very quickly. And that's the big reason why we don't really look at the neutrophil, because the lifespan of the neutrophil is very short, where the lifespan of the lymphocyte is longer. And this is why we look at the lymphocyte versus the neutrophil. Of course, monocytes are too small in number. Of course, the basophils and eosinophils are also very small in number, so we don't have enough cells to really look at if we're looking at those white blood cells. And since the lymphocytes, as you know, have the second highest content of circulating white blood cells, it's one of the reasons why we look at the lymphocyte. And then you can see the plasma. Look at the difference between the plasma vitamin C and the lymphocyte vitamin C. So this is another example why plasma vitamin C testing is not very accurate. And yet this is a schematic, and this, you can see this was published in 2016. And like I said, there's other literature that will support that as well. So when you look at the literature, whether it's New England Journal of Medicine, European Journal of Clinical Nutrition, British Medical Journal, through the years, you can see they look at the plasma, they've looked at the serum vitamin C, which of course is ascorbic acid, and then they've looked at the leukocyte, primarily the agranulocyte, the lymphocyte. And they've shown here, it says the leukocyte content reflects the amount of vitamin A available for storage, and also usage, where plasma or serum vitamin A just reflects the recent intake of the nutrient rather than the stores. So it's floating around in this liquid outside the cell, and we know that no biochemistry occurs outside the cell. Everything that you've learned, whether it's protein metabolism, lipid metabolism, carbohydrate metabolism, it's intracellular. So once again, going back to Dr. Shive's philosophy is, why are we looking outside the cell rather than inside the cell? Magnesium, a lot of people, of course, still do this. I see this all the time in my practice, where people come to me and say, oh, you have severe muscle cramps, or I have severe muscle pain, or I have fibromyalgia, or I have hypertension. And of course, my doctor said it could be related to magnesium, and he did some magnesium tests. I said, well, what kind of magnesium did he do? Well, he did serum magnesium. Well, you can see here that less than 1% of the total magnesium is in the blood, okay? Serum magnesium, we've known this since 1980. As you can see here, I noted the reference. Since 1980, we've known that serum magnesium is an unreliable indicator of magnesium nutrition status. But we keep doing it, okay? So I'm going to tell a little story and why people do things, and sometimes we don't even know why we do it, but because our mentor told us to do it that way, so we did it. So here's a little story about, Thanksgiving dinner. And daughter is watching her mother make Thanksgiving dinner, and she's standing the turkey up, and she goes, Mom, why are you standing the turkey up? Why are you not laying down the turkey that way? She said, well, that's the way my mother did, so why don't you call Grandma? So she calls Grandma, and she asks the same question. She says, Grandma, Mom's making Thanksgiving dinner, and she's standing the turkey up rather than lying it down. Why did you do that? She says, well, that's the way my mother did, so why don't you call your great-grandmother? So she calls her great-grandmother and asks the same question. And of course, you're thinking, okay, there's got to be some really good reason why she stands this turkey up rather than lie it down. It's got to be maybe cooks better, whatever. So she asked her great grandmother, why do you stand the turkey up? She said, because I never had a pan big enough to lay it down. So you're thinking, oh, we got to keep doing serum testing because that's the way my mentor did it. That's the way I learned in school. Well, instead of saying, well, wait a minute, is there a better way of looking at things? And of course, we have found through these various citations that I'm showing you that there is. And I can tell you through 30 years of using technology that it definitely makes a difference. And you can see here, back in 1986, in the Journal of Magnesium, mononuclear cells are probably the compartments which best correlate with muscular magnesium. So we're looking intracellularly in 1986, and this is something that has been overlooked for years. And like I said, this is independent literature out there. Then they looked at the lymphocyte in regards to cardiovascular, and they said, well, was there some correlation? You can see here in the International Journal of Cardiology in 2011, so 12 years ago, that they found that a decrease in the intralymphocytic magnesium was associated with diastolic heart dysfunction in people with essential hypertension. So this is, once again, if you've been looking at people that have high blood pressure and they are looking at serum magnesium, say, oh no, you don't need magnesium because your serum magnesium is good, you're not looking at the right compartment. You need to look at a different cell, which is a lymphocyte, and it's going to give you a better standing with magnesium than the serum is. Okay, and I gave you that example with serum calcium, the same thing. People are, looking at serum calcium and saying, oh yeah, serum calcium's high. Well, once again, is it a hyperparathyroidism problem? or is it a toxicity of calcium? It's very, very rarely are we seeing a toxicity of calcium. Most people don't even consume over 700 or maybe even 800 milligrams a day of calcium. So the chances of having calcium toxicity because you have a high serum calcium is very, very rare. So once again, people are doing that all the time. So I'm going to show you something here that's very interesting and why we can't just assume. And, there's a lot of times I'll admit, early in my career, I've done the same thing where you look at people that have the same signs and symptoms and you say, man, they have this condition because I've seen these signs and symptoms over and over and over. So that's what they have. So here's an example, and this is actually cases out of a journal that I'm going to show you here in a second, the citation, that this individual, or these individuals, 25 individuals actually, and they had this, of course, presentation. And if you look to the right, they have I'm showing you the exact same signs and symptoms. Now, if you look to your left and you see that column, you say, oh, I know what that is. That's multiple sclerosis. And you're right, it is multiple sclerosis. People have MS, have these signs and symptoms, they have these presentations on MRI findings and so on. But did you know that copper deficiency presents the exact same way? So how many of you have seen MS patients out there and say, oh yeah, you have the optic neuritis, you have the demyelination, you have all this, and you have it, okay? But did you realize that they could also have a copper deficiency? Because copper deficiency actually helps maintain your myelin. And this is why, once again, a person that has peripheral neuropathy that comes to you, and the typical old school workup of neuropathy from a nutritional standpoint is I better pull a serum B12, I better pull a thiamine, serum B1, and maybe B6, okay? And those are the 3 or 4 nutrients that they look at. And if those are normal, boom, it's not nutrition related. And I kind of chuckle sometimes when I read articles on neuropathy and they say hereditary neuropathy. What does that mean? I mean, if you don't have an answer, it's like, oh, I'm going to throw it into hereditary neuropathy. It's hereditary, right? Just like people all the time are told, oh, you have hereditary hypercholesterolemia. Is it really hereditary hypercholesterolemia, or is it a family member had 1 or 2 deficiencies, the same thing as you do, and so you have that because you're the son or daughter of your parents, but because they have it, it's hereditary. It might not be hereditary. It might be a nutrient deficiency that maybe the same lifestyle occurred from, maybe they passed on, maybe mom and dad ate a certain way, and now this son and daughter eat the same way. But how many of you have thought about copper deficiency if someone comes into you that has peripheral neuropathy? I will bet very few of you, and yet it's more common than you realize. Now, in this article, it was published in the Mayo Clinic Proceedings, and you can get this online in October 2006. It was involving 25 individuals, and one of the major reasons that this occurred was some people were taking too much zinc and they weren't taking coppers. And that can happen. If you take too much zinc, you can actually cause a copper deficiency. We usually look at a zinc to copper ratio at about 10 to 1. Some people say 7.5 to 1, but I can tell you from a clinical standpoint, if you take one at 15 to 1 long term, if you take 15 milligrams of zinc or greater than that over 1 milligram of copper, you will eventually push someone into a copper deficiency. Now, I don't want to spend too much time on copper, but I just want to say this, that copper is very important for the cardiovascular system. There's a lot of evidence that's showing that copper deficiency helps with cholesterol, helps with triglycerides. We even know that copper helps with affecting HbA1c, but a lot of people take this nutrient for granted. The one thing that's important about copper, just like some other nutrients, is that people are taking H2 histamine antagonists, or they're also taking PPIs, then when we cut down the production of hydrochloric acid in the stomach, we actually increase our chance of B12 deficiency. And people talk about calcium also becoming malabsorbed. Well, this is another nutrient that's highly malabsorbed. So if you have people that are on long-term PPIs or H2 antagonists, then once again, You're looking at possible neuropathies. You're looking at problems down the road, like this anemia and so on. And it's once again related. So let's talk about anemia. Okay, so here's a little quiz for you. I want you to take a few seconds to look at this and say, okay, I want you to tell me maybe what you think this anemia is and what you would do for this patient. So, you order a CBC with a differential, and this is what you get. Now, I'm going to tell you a little story, and this is actually true. I gave a lecture up in the East Coast one year, and I did a similar presentation like this. And I handed, there was over 100 doctors in the room, and not one single doctor got this answer right. 101 doctors, okay? They were looking at the simple CBC that you and I look at all the time. There is no way even the best hematologist can look at this and tell me exactly what's wrong with this patient without doing further diagnostics. So what's your diagnosis? Ask yourself that. And what would be your treatment? If you're just looking at CBC and you receive this, think in the back of your mind, and that's your answer: copper deficiency. Copper deficiency presents like this. Copper deficiency presents just like iron deficiency does and some others. So I'm going to show you some information on this. And this is why we do functional testing, and we look at several nutrients and not just one or two. So if you have a person and you do a CBC with a differential and they come back in a presentation, microcytic anemia, unless you do further diagnostics, there's no way you can tell me what you're going to give that patient, or you're guessing. Now you can say, okay, it's a woman in childbearing years. She's got a menstrual cycle. Yep, I'm going to give her iron. Okay, well, that's fine. But how do you know it's not zinc, copper, riboflavin, B6, vitamin D, or vitamin C? You don't know. You may correct it. Okay, you may give her a large amount of iron, but once again, if you can mask it, and that can happen in macrocytic anemia a lot. People have an elevated MCV, and maybe it's a folate deficiency. If you give enough B12, you will actually correct or change that MCV number, and you say, oh, that was the answer. But you can mask that. So by giving too much folate or too much B12 or too much vitamin C, you can actually mask something else. So this is why we have to look at all these. And that's why when people come to me and they say, oh yeah, doc, I'm coming to you because I'm tired. My doctor did a test and they told me I'm anemic, but they gave me iron. I said, okay, well, did they do an iron profile? Did they do some other testing? No, they just said that it's iron. I said, there's no way. There's no way they know that unless you do some further diagnostics, because you can see here, these are the nutrients, and this isn't even all of them. I took the major ones, but there's even some more in some of these groups. But you're looking at this and saying, wow, I have to consider all of those when someone's anemic. And the answer is yes. And which one it is, and it might be a combination. Who knows, right? So once again, that's the biggie. That's another one that people look at, and that's that. So most time when people are iron or they're anemic, what do? We do a serum iron. And some people do a full profile. They'll do the TIBC with the ferritin and so on. That's good. Or they'll do serum B12, or they'll do serum folate. Well, think about that. What did I say? Serum. None of those tests tell us if those nutrients are getting inside the cell. So we've all heard about the methylation pathway. Why do we do this? Well, you can see that there's steps in here involving different nutrients: choline, B6, B12, folate, all these come into play. So when we look at a person that has an elevated homocysteine, then what do we give them? Well, you don't know. You're going to guess, because if you say, oh, they have elevated homocysteine, I'm going to give them a B complex. Well, it might have B6, might be a B12, might have folate, might have B1, might have B2, B3, and so on. But it might not have choline, but yet choline's involved. So how do you know you're not missing a choline diagnosis? Because you're giving this. And yeah, the homocysteine may change a little bit, but did you optimize it with all the nutrients? Or it might be a cysteine problem or a glutathione problem. So this is a functional test. Homocysteine is a functional test. And I'm sure all of you are familiar with homocysteine for stroke. We see it with heart disease, heart attacks. We see it, of course, with Alzheimer's now, but how many of you realize that homocysteine also should be monitored if you're looking at bone, if you're looking at a person that's osteopenic or osteoporosis? We know that it should be looked at, and you can see that this talks about it right here. And there's a lot of research on this, that homocysteine is often elevated in people that have osteoporosis or fractures, whether stress fractures or more serious like vertebral or femoral fractures. And the point is, homocysteine is a functional test. So if you have been ordering homocysteine, you have been doing functional testing. This is not a static test. Now, the thing that's important about this, about homocysteine, and realizing there's several nutrients that affect this. And these are some of them. So once again, if you look on your reading left, except for the bottom one, say, oh, I gave a B complex because my patient's homocysteine was elevated. Okay, well, did you give them vitamin D or did you check vitamin D? Well, did you check the things on the right, the choline, the serine, the glutathione, the cysteine? So any of these individually in combination can cause an elevated homocysteine. So think about this, depending upon who you read, anywhere from 65, 70% to 90% of the US population, well, even I should say world population, has a vitamin D deficiency. So if that's true, let's just be conservative, say 60%. 60% of those people have vitamin D deficiency, then those same 60% could have an elevated homocysteine. So you're looking at coronary artery disease, you're looking at stroke, you're looking at, osteoporosis, so Alzheimer's. So are we going and looking at those tests? And this is why you want to go and do a functional test, is something like homocysteine. And then once you do a homocysteine, if it is elevated, then you have to go backwards and say, okay, now what do I do to look at the nutrients that involve homocysteine? It's like, it drives me crazy when I hear this all the time on advertisements. Oh, if you're osteoporotic, make sure you take your calcium and vitamin D. Wait a minute, homocysteine is involved. Now, I don't see calcium on this list. I definitely see vitamin D on this list. But what about your B vitamins? And what about these amino acids? What about these metabolites like choline? Are they saying you should do that also for osteoporosis? No, they're not. But they should be, right? Because it's involved. So here's some research to support what I'm saying is, when we look at probabilities, anything lower than 0.05 says it's definitely valid. And here's an article out in 2020, June of 2020, showing you women with low BMDs and women with normal BMDs and the homocysteine. As you see, women with low BMDs or good status, of course, I should say bad status, is they had a high homocysteine. Women with normal BMDs had a lower homocysteine. They had an 8.87 on the average, plus or minus 3.24. And the people that had the low BMDs or the bad, of course, studies had 14.93 plus or minus 3.83. So once again, very important to watch. They looked at women with homocysteine levels, once again, greater than 12, and women with less than 12. And once again, you can see the T-score on the BMDs, once again, correlated with the homocysteine. So once again, a functional test. Important test. I think a test, I learned about this test 40 some years ago in my training. And of course, at that time, everybody, a lot of doctors would say, oh, Ron, don't worry about that. That's just genetic. We don't worry about that. There's not really a lot of literature on that. So I'm thinking, okay, that's not true. So I started investigating 40 some years ago, continue to keep my eye on homocysteine. It's a standard now in my practice. If you're a female or male that have osteopenia or osteoporosis, you are getting a homocysteine test done at least once a year, period. Because I want to know what that is. So when we talk about kidneys, of course, one of the things everybody goes on is let's look at their BUN or let's look at their creatinine, right? Or let's look at the BUN creatinine ratio. Okay, and that makes sense. I used to work dialysis. I was a dietitian on dialysis unit for years. So once again, very familiar with this, but the question is it really the test we should be looking at? Once again, a lot of people do it because that's the way their mentors told them to do it, or that's the way the professors told them to do it. But what about creatinine and cystatin C? Have any of you even heard of cystatin C? A lot of people haven't even heard of cystatin C, and yet Very important test, as you can see here. Now, even though it's a serum test, but it is kind of a functional test because the way it goes through the body is serum cystatin C has been shown to be a better marker of GFR than serum creatinine. And this has been shown for years, but I just cited one citing here in, once again, this journal in 2013. So the question is, you have a diabetic that's not well controlled. Are you still doing the creatinine? Are you still doing the BUN? Or should you maybe do the serum cystatin C? The point is, once again, moving forward, becoming more progressive, ordering the right test, right? So that's very, very important. And once again, I used to teach clinical lab diagnosis for 21 years here in Houston at the chiropractic school. And I used to tell my future doctor students this all the time. If you don't prepare your patient right, meaning like if they need to fast and you don't have them fast, you're not going to get the results. And if you don't order the right tests, you're not going to get the proper diagnosis. So the whole point is, if you keep going with the serum magnesium, serum B12, serum folate, you're not looking at the right test, and you're not going to really catch a lot of people that need those nutrients or even this function. So this is the test that I use. This is from Cell Sciences. It's called Cellular Micronutrient Test, known as the CMA, and you can see all of these nutrients are looked at. These are based off a proliferation, and I want to emphasize that proliferation of the lymphocyte. So what they do is they actually add nutrients to a solution one at a time to see if the lymphocyte proliferates. Now, think of it this way. If your gas tank is full of gas and I try to put more gas in it, I can't do it, right? So it's not going to be any benefit to it. So if your cells already have enough, I'm just going to use, say, biotin, since that's on top. If it has enough biotin and I add more biotin, it's not going to make those cells proliferate anymore because it already has enough biotin. But if I add biotin to it and the cells really start to proliferate, then that shows me that that cell, from a biochemical pathway means internally, is not functioning properly and needs more biotin. And so depending upon the percentage of proliferation, that's why you see percentage signs next to these, the proliferation of those cells helps determine, are they slightly deficient, which they would say borderline, or are they severely deficient, which they note is insufficient. It's based on functionality. It's based on those, the glycolysis and the Krebs cycle and so on. And you can see there's numerous nutrients we check. So when I showed you those examples of anemia, and we talked about homocysteine and so on, boom, you do this panel and you can see it picks up all those. So you don't have to guess. I don't think any of you want anybody guessing on your health. I definitely don't want anybody guessing on my health. And I'm sorry to say, but a lot of doctors are still guessing on people's health because they're looking at this, or how many times, and this is the thing that really put a light bulb in me when I was young in my career. I was working in a hospital. I had some very intense floors. I had the endocrinology floor, I had the surgery floor, I had the gastrointestinal floor, and I had dialysis. And a lot of these patients were really sick. And these doctors would order serum B12, serum folate, and maybe even serum B1, and boom, they're all normal. I'm like, dang, if they're all normal, what am I here for? I mean, if all these tests are normal, these people are sick, then what am I doing here? Because I really don't need to be here because all these tests are normal. Well, once again, as I got further into my career, I said, well, that wasn't a good test, and that's why they were normal. They were looking at the wrong compartment because that's what people were trained, and they kept passing that along from school to school to school. So hopefully that opens your eyes to something. Then there's another part of this testing that Cell Science does. It's called the antioxidant protection assay. This is not a deficiency test. What they do is they test these particular products on how the cell responds to a hydrogen peroxide challenge. So once again, they put those cells in hydrogen peroxide, they see how the cells react as far as how fast they break down, and then they go back and they test that same solution with the cell, and they add each one of these products individually. And so, say, for example, I added elderberry to the solution, and say the cell initially only lasted 30 minutes, now it lasted 60 minutes. We know that that elderberry was protective as an antioxidant and or an anti-inflammatory for that particular patient. It's a very individual thing. It's not the same. And you can see this example that's up on the slide is showing you some highly protective or some protective. And so if people say, well, yeah, I took turmeric and it really, really worked, and say, well, that's great. Well, if you look at this particular example, if you go to the far right column on the bottom, it says turmeric, highly protective. Yeah, that person would respond well to turmeric. Well, the next person might say, well, I took turmeric and didn't do anything for my joints. Well, they might not have a protective or highly protective sensitivity to it. So this kind of tells you, will something like that work for an individual or not? And I have some very amazing cases. I don't have time for it today, but some very amazing cases where this particular part of the testing really showed me what to use with the patient for a highly inflammatory condition or an autoimmune condition to really see if it's going to work or not. So I know I'm coming to the time frame where we open up for Q&A, but once again, this is some information that if you're interested in cell science testing, once again, you can contact Robert Weldon at this particular number or email, and he can help you as far as becoming a client of cell sciences and getting to some of their testing. And like I said, I just showed you two of the tests, and they have numerous tests available. But like I said, the CMA and the APA are two that I just wanted to more or less introduce you to. So Adrian, I'll open it up for any questions.
Yeah, amazing. Thank you so much for that fantastic presentation, Dr. Grabowski. We had a ton of questions coming in, and so if you do have any questions, please use that Q&A button, like I mentioned in the chat, and we will go from there. Just to make things easier, I won't be going through the chat, as it does tend to kind of jump from place to place if you are writing in there. So please use that Q&A button, and we'll go chronologically. So you explained what plasma and what serum are, but some functional blood testing involves whole blood. What precisely is whole blood?
Well, that's when you're looking at all of it. You look at the serum, the plasma, and the cells all together. So you're looking at nothing has been separated out.
What helps the nutrients get from serum into the cell?
Well, of course, there's receptors and the cell membrane integrity. The cell membranes are made up of lipids primarily. And so you have, your omega-3, your omega-6, your omega-9, and your phospholipids, and those come into play. And if those are not adequate in the cell membrane, then we see some problems with nutrients getting in. I see that all the time where people are taking good sources of, say, vitamin D being a fat soluble, but they're low in omega-3 or they're low in omega-9 in the test. And until we correct that omega-3 or omega-9, they don't get that vitamin D in there properly. Or once again, there's a lot of research being done like on vitamin D receptors. And there may be other receptors out there that we're going to be finding more and more in the future that are also inhibiting some of these things from getting into the cell.
Perfect. Can high B12 be from serum not getting into cells, or can it be related to form, i.e. methyl not tolerated due to a SNP?
It could be both. Yes, it could be problems getting into the cell, or it could be due to a SNP. Absolutely. So those are things you have to look at as well. And that's why I'm a strong proponent of genetic testing. I think that's really another part of this whole nutritional intervention.
Yeah, wonderful. Can you explain in the context of measuring ferritin levels? And this is in previous, I'm not sure exactly what context you're speaking to in this slide, but how can we understand that in comparison to just serum iron levels, transferritin, TIB-C?
Okay, so ferritin, of course, is a process of storage of iron. And so we're looking at it, that it doesn't have a real long half-life, but it is a means of kind of looking at storage versus a snapshot of the serum. So once again, it's a protein that's connecting with the iron. And so that's really what we're looking at. So some people look at that as a little bit longer term. It doesn't have a huge, it's not, doesn't stay elevated for like months. The thing is this about ferritin is also what we call acute phase reactant. So it can be very misleading. You can have a high ferritin and think, oh, this person has a lot of iron, but it could actually be due to an inflammatory process going on. So for example, if a person had autoimmune disease like lupus or something like that, something like that, they could have an elevated ferritin rather than a high amount of iron intake.
Perfect. So we were talking about magnesium and potentially how unreliable it is measuring within blood, going back to the 80s, well documented, obviously, but is it reliable to measure magnesium in the hair? And are there other more reliable sources to measure?
Definitely hair analysis is still being used in forensic medicine. So the minerals, yes. I mean, you can still use hair analysis as the minerals. It will not, the hair analysis is not beneficial for vitamins. So once again, you have to look at a couple things. So as I mentioned, there's a lot of nutrient interactions that we have to consider. For example, if you take a high amount of magnesium, because you might have a low magnesium in the hair per se, you can actually cause a B1 or a thiamine deficiency. Well, how would you determine that in hair analysis? You can't, because it doesn't look at that. So by looking at hair analysis, you're getting the minerals, but you're not getting the vitamins. So you need that correlation. You need to see all of those at once to see if you are causing an imbalance of a nutrient.
How does RBC magnesium compare to mononuclear
It's
magnesium?
good. Well, it's short term. I mean, it's a little short term. If you think about it, like I said, the red blood cell has a normal, I say normal because if it's a somewhat healthy red blood cell, normal lifespan of 90 to 120 days. The lymphocyte is anywhere from, depending upon who you read, 3 months to 9 months to a year. So you get a longer lifespan, you look at a longer duration. So it tells you a little bit more for a longer period than red blood cell. But the red blood cell is very reliable. It's just a shorter term.
Perfect. And I am getting this question a few times in the chat. This is, of course, being recorded, and we will distribute it via email once our teams have the opportunity to do some edits to it. And how does one develop copper deficiency?
Oh gosh, several things. One, you can be taking too much zinc. Two, you can be taking, like I said, a PPI or H2 histamine antagonist, something like that. That's causing a decrease in acid production. Overall, you can be consuming too many phytates or oxalates in foods. That's another way that you can do that. So there's a lot of ways like that you can do it. It can be medication induced. It can be too much of another nutrient. A lot of your divalent cations like calcium, magnesium, zinc, copper compete with each other in high dosages. And so if you take high doses of one of those, it can interfere with the other.
So if you eat a lot of nuts, aren't you getting a lot of copper, even risking relative deficiency in zinc if you're not supplementing with the latter?
Okay, so once again, this is the thing that it's we really want to emphasize to all of you and emphasize to your patients. Just because some food says it's high in that nutrient doesn't really mean that it is. And what I mean by that is they've done some studies where they've looked at the same nutrient or same food, like say Brazil nuts from different parts of the country. And from one part of the country, 3 or 4 Brazil nuts would have a certain amount of selenium versus another part of the country would have a lower amount of selenium. So just because you read something, 3 Brazil nuts will give you 100 micrograms of selenium. One, it may contain that, but did you pull it out of that? Are you able to extract that selenium out of that food and actually absorb it and then get it functional? So too many times people say, they just assume that, oh yeah, I'm consuming high copper, high selenium, high iodine foods, I should be normal at. No, I mean, you might not be extracting it out of that food. And plus it may not be as high as what it says on that label.
What was that ratio that you mentioned for zinc to copper?
10 to 1.
10 to 1. Perfect.
If you go above 15 to 1, you have a better chance of going copper deficient.
Amazing. How long in advance should patients stop vitamins prior to lab testing?
This particular lab test, you do not have to, because it's a functional test. It's looking at cells that are already containing these nutrients. If you do a serum test, you have to stop it, of course, a day or 2 days before, because you're actually going to mislead that serum testing or plasma testing. But in a functional test, it's just like, and to answer that question, it's just like saying, do you have to have your diabetic fast for the A1C? No, you don't. Why not? Because that glucose is already hooked onto that hemoglobin inside the red blood cell. So they can eat the day of coming in and do an A1C, and it's not going to affect that A1C because it's a long duration functional test.
Perfect. What is the cell needs? What if the cell needs 2 or more nutrients to proliferate if only one nutrient is added at a time? What are the cell needs?
Well, you're looking at that particular nutrient for that, function of that part of the cell. So it's still going to function But when you're loading it with that particular nutrient, if it's adequate of these others, you're going to find out what those other nutrients are missing when you start doing the other proliferation. You're going to look at a percentage. So they're going to proliferate, but the message is, are they proliferating more with one particular nutrient? And because that's why it's so important that you look at all those nutrients individually to see which one, or if one is adequate versus the other. So if you're adequate magnesium, but you're checking biotin, the cell's going to still proliferate, but it's going to proliferate more if they're low in biotin because you're adding more biotin.
Perfect. And I'm just going through what's the best test? What's your favorite test for thyroid function?
Well, I don't know if I'd say best test. I'm just a big proponent of thorough thyroid. The total T3, the total T4, the free T3, free T4, TP. I can't tell you how many times I've got people with autoimmune thyroiditis by doing the TPO antibodies, and yet people come from endocrinologists or general practitioners or whoever and say, no, I just do the TSH and I just do the T4. There's a lot of research out there to show that you can have a normal TSH and normal T4 and still have thyroid dysfunction. So I think we all need to really do the thorough thyroid panel. I don't know why people do a limited panel.
All right, absolutely. Don't the antioxidants need to be metabolized by the liver for complete efficacy, testing, and not placed next to blood cells?
I'm not sure if I know what you're saying. I wouldn't say they have to be metabolized. I mean, you look at antioxidants, they have to be present everywhere in the body to protect the systems. I mean, the liver is one, but I wouldn't say they have to be metabolized only in the liver. I'm not really sure what you're trying to ask on that question, honestly.
Yeah, and maybe if you want to write a little bit of clarification if you're still in here. And folks, I know we are heading up to the hour. Just a quick call out. At the top of the hour, we're going to hop into a quick demonstration of cell sciences, or excuse me, of Rupa Health, and I'll show you exactly how to order these tests through Rupa Health from Cell Sciences, as well as offer a bit of a coupon. So stay tuned on how you can learn a little bit more about that. So moving back to the questions, I just had a client with serum vitamin D 134, but on this test, it was flagged very low. Do they have to stop taking vitamin D or take more?
No, well, that's a good question. And this is the thing you have to think about. One, they might have a vitamin D receptor problem, so they might not be utilizing because of VDR. And so that's where I would do some genetic testing. Now, what I'd also look on that test, and this is why it's important when you evaluate this test, is you want to go look at these products. You want to look at biotin, you want to look at pantothenic acid, you want to look at the omega-3s, omega-9, choline. Those are major players with cell membrane integrity. And a lot of times you'll have one or more of those deficient. And once you correct those, then the vitamin D will get inside the cell. But once again, you're looking at a snapshot. You're looking at a serum test. And I know a lot of people are looking at that as far as if you go over 100, it's dangerous to the body and this and that. Some say 120 for the serum vitamin D. The question is, why isn't it getting into the cell? That's the big question.
Yeah, absolutely. You spoke about the importance of looking at homocysteine for these nutritional deficiencies. What about looking at methylmalonic acid? Can you extrapolate when that would be important?
Well, that's going to be more if you're looking like the biotin. I showed you that how biotin comes to play in that pathway, and B12 comes in that pathway. But that's for more B12 relationship. Homocysteine involves a lot more nutrients. So if you want to look at homocysteine, and that's abnormal, you could have a normal B12. Well, let me say this. You could have an abnormal methylmalonic acid. And yes, you could have a homocysteine that's abnormal because of that B12. You could have a normal methylmalonic acid and still have a bad homocysteine because B12 is not the only thing that affects homocysteine. There's several nutrients that affect homocysteine. So if you have a bad homocysteine, and you say, well, I have a elevated homocysteine, I'm going to go look at MMA. You go look at MMA and it's normal. Say, well, that doesn't make sense because MMA is normal, but homocysteine is abnormal. Yeah, it does, because B12 is only one of the players in homocysteine. And so you get a better idea if there's more nutrients involved with homocysteine than you do with methylmalonic acid. You're isolating primarily biotin and B12.
When do you use adenosine or hydroxyl forms of B12?
If I suspect a person is over-methylating, I will use adenosine or hydroxy for that. As far as the whole methylation, I believe in going forward slow. I don't like to give high dosages of B12 and high doses of folate, methylfolate, because I think you can have a better chance of over-methylating. But if people seem to react poorly to methylcobalamin, then I will do the adenosine or hydroxy.
Perfect. We are at the top of the hour. We have a couple more questions. Do you have to hop?
No, I'm fine.
Okay, great. Let's hop through these last couple ones, and then we'll transition into the Rupa Health demo, and I'll show you exactly how to order these tests from Cell Sciences directly on Rupa Health. What about excess copper factors?
Well, definitely. I mean, you take excess copper, you can start to interfere with the other divalent cations. You can affect the calcium, magnesium, manganese, and the zinc the same way. So, that's something to consider. Now, once again, we get a lot less copper in foods than we do zinc and some of those other divalent cations. So the tendency for copper toxicity is not real common. It can occur, but once again, and then you have to look into things like Wilson's disease and other, maybe genetic problems.
Iodine measurement. They read that it needs to be challenged to get proper measurements. Do you have any comment on this?
I mean, some people say that. I mean, I find this, iodine on this test is very beneficial. This is a thing that, in fact, I just had a clinician that talked to me a couple of days about this. In the literature, and I find this clinically as well, that a lot of people like to give iodine if they think it's a thyroid issue. But there's research to show that if you are low in iron and or zinc or selenium and you give excess iodine, you can actually cause major problems. So you really want to look at those four nutrients as very synergistic with each other. And before you start just going and giving iodine, you really want to know the iron, the selenium, and the zinc status.
Let me go through. We're running through these questions, folks, and I appreciate that. How often do you need to retest a patient for micronutrients?
No more than 6 months. So you want to do at least 6 months of more or less support, and then you retest 6 months. So 6 months is the earliest that you can retest.
We have a bit of a scenario question coming on. So if you have high/normal serum nutrient levels and low intracellular levels, would omega-369 and phospholipids be your treatment? I guess, what would your treatment be?
It would be if those were abnormal on the test, because they measured that. Cell Science measures those. So yes, if they're low on the test, absolutely, that'd be one of my considerations.
Perfect. What tests should be commonly ordered for the patient with osteopenia?
Well, of course, besides the BMD, I would definitely do the cellular test, the CMA, and homocysteine. Those are two standards that I do because, and I did two webinars. I did a part 1 and part 2 webinar. And if you become a client of Cell Science, you can actually listen to those because they're recorded in January and February on osteoporosis. And I go through several testing mechanisms along with different nutrients that are involved with osteoporosis/osteopenia.
Last couple questions we got for you, Dr. G. Why is it important to order nutrient panel versus single nutrient test?
Instead of a single nutrient test?
Correct.
Well, because once again, I give you an example with magnesium. Say you did an RBC magnesium test and you said, oh, they're low in magnesium. I need to give magnesium. Well, once again, magnesium over supplementation with magnesium can cause a B1 deficiency. How do you know that you didn't push them into a B1 deficiency unless you're monitoring that? So that's why you want to, always look at a bunch of things. That's why I hate to say this, there's a lot of great institutions in this world, but when you do research, especially nutrition research, they always are trying to limit the variables. And I understand that because I've done research. But the point is, in nutrition, so many nutrients play along with one another. So when you're looking at vitamin D or you're looking at magnesium or you're looking at calcium in research, what about the status of the others? I mean, if you're looking at vitamin D, why aren't you looking at K2? Why aren't you looking at calcium and so on? So I think sometimes this research out there is very skewed because we're not looking at complementary nutrients.
Yeah, and that makes a ton of sense, right? It's best to get the whole picture, know your numbers. How old should an individual be? Is there an age limit before we do these testings?
Nope, I've done as young as an 8-month-old.
Oh, wow.
On this testing, yeah. In fact, I started testing my kids. I have 3 boys. I started testing my boys since they were 1 year old.
No way. That's incredible.
They don't know what life is without supplementation.
I'm newly adopted. I hit my 30s and I just felt something that was a little off in my body, and adding supplements into just my regular regimen made all the difference. And I
Oh
think that's
yeah.
for another day. And I feel like we can have a conversation about that in person, probably for hours.
Oh yeah.
But Dr. G, thank you so much for
You
your
bet.
time this afternoon. How to reach out to Cell Science is all on the screen. As you can see, you can reach out to connect.cellsciences.com and reach out to Robert Weldon at cellsciences.com as well with the phone number there. And you're welcome to stay around and stick around and check out how you can order this test from rupahealth.com. Additionally, what I'm going to talk about right now as we transition is the offering that Cell Science is so nice to put out there is the offering for a coupon with the details to come on how we can save y'all some money when you are opening an account with Cell Sciences. So let's go ahead and transition right in. I'm going to steal the screen
Okay.
from you.
And Adrian, I just want to thank you and Rupa.
Oh yeah, absolutely. Any final thoughts?
Nope. I appreciate everybody that's online listening.
Thank you so much for it. I'm really
Okay.
excited. And again, y'all, we're going to go ahead and send out the recording along with the slides. And we appreciate you. And we're looking forward to doing more work with you down the line. Awesome, everyone. Well, with that, my name is Adrian Martinez. I appreciate you all for sticking around, all hundreds and hundreds of you. For those of you who don't know me or maybe just new to introduction to Rupa Health, we're a functional medicine lab platform, and we're designed with a goal in mind just to really make life easier when it comes to functional lab testing. And right now, there are so many different pain points when you do think about lab testing, right? Everything from having all of your different accounts from the different labs you want to order from to managing all of the results as they come in, and not to mention the paperwork and the patient experience that can be involved with that. Expanding even upon just the actual ordering process and operation around that is education, right? Where are you coming to learn about all of the different tests that are on the market? And so Rupa Health is available to help provide a solution to all that. And so you're actually all a big component of Rupa Health right now, part of Rupa University. So we partner with 30 plus labs, of course, including Cell Sciences, to not only make them accessible and available on our site, but also to provide you education. And so with that, let's jump right in. Hopefully you can all see my screen. I'm going to hop out real quick and just do a quick reshare again, just to make sure. But Rupa Health is a free account to sign up for. And through Rupa Health, you get access to over 30 plus labs, over 3,000 different tests all in one place. And of course, again, including those from Cell Sciences. You have access to not only just all the tests in one place, but also education as well. To show you just really how simple it is to place an order, I'm going to make my screen a bit smaller here. Once you're in the dashboard, all I'm going to do is hop in to start an order. I just need the patient's first name, last name, and email address. I'll hop right into the order screen here. And once in this order screen, you can see I can do things like setting up custom bundles. So bundles of tests from any one of the labs that we work with, you can put them in a single bundle, one click, add it into your cart. So I don't have to go to 5 different, lab portals to order my tests. It's all here available for you. I can also create a favorites list. So individual tests that I want to order, I have them available for me up at the top. So I'm ready to order that micronutrient assay from Cell Sciences, one click, and then I just click send a patient, and that's it. But if additionally I want to order other tests that I feel might be comprehensive to my patient, I'm able to have access to them all straight away here. But again, once I press send order, that's it. We offer wholesale practitioner pricing, which means the same prices that you would get having working with an account directly with the labs are the same prices that we offer here at Rupa Health. And once you press send on that order, we can effectively take it from there. So we'll reach out to the patient. We can handle billing with the patient. We offer multiple different payment solutions. We can do credit, cash, or credit, debit, HSA, FSA. We can set up a 3-month interest-free payment plan with the patient. We'll send over instructions and FAQs walking the patient through how to take the test. We'll handle any support questions that come through. We can even help coordinate phlebotomies, and we'll even handle any specimen issues that come up. So really what the goal here when it comes specifically to the testing operation is to offload a lot of those required admin experiences that are on your end off your shoulders onto ours. So you come to Rupa Health, you have access to all the tests that you need in one place, press on in the order, and then we will go ahead and take care of the entire patient experience. We'll ship the kits to the patients, so you don't have to stock any kits in office. Additionally, we'll send over very detailed, but also very user-friendly instructions to your patient. If they need anything, they just respond to any of the communications that we send, and they will get access to it directly to our support team. From there, you're notified as the result comes in, and you're able to just jump right back into your main Rupa Health dashboard and see all of your results in one place. So you can see all of your in progress orders. I can click into one at any given time, and I can see, hey, here's 3 tests from 3 different labs, or 4 tests from 4 different labs, right? It's all available right here at the click of a button. I can download the results. I can send them to my patient. I can even schedule a clinical consultation. So if I do need maybe some assistance interpreting these results, I have access access and the ability to reach out and speak with a clinician from the lab that I'm working with to help interpret those results. Now, like I mentioned a moment ago, Rupa Health is free to sign up for. The only cost to use Rupa Health is a 7% processing and ordering fee on each order, and that's paid for by whoever's paying for the tests. So if you're having us manage billing directly with the patient, meaning the patient is the one paying for the tests directly to Rupa, then the patient will be the one paying that 7% fee. In that scenario, Rupa Health is free for you. The only time you would ever pay anything to Rupa Health is if you decide to pay for the order yourself, right? It's as simple as that. Now, to create an account on Rupa Health, you can either be a licensed practitioner to be able to order the tests, but if you are a practitioner whose licenses or certifications may be limiting in your ability to order testing directly, we do have a program called Physician Services. Now, Physician Services will partner you with a licensed physician to be able to order those tests on behalf of your patient. And if you do have any questions about that, feel free to reach out directly to me. More than happy to dive a little bit deeper into the details of that. Now, like I mentioned a moment ago, Rupa Health is more than just somewhere where you can order your tests, right? We have the ability to be able to be creating amazing content because we do have 30 plus different lab partners that are fantastic, right? And so we create webinars, we have boot camps. You can hop in and dive in and learn more about the different tests that are on our platform. You can browse by category, search all the different lab companies that we partner with. We can even compare tests. So if there are specific tests that you want to hop in and say, hey, what are all the different SIBO tests? What are all the different GI tests offered on Rupa Health? We can actually even create these lab test comparison tools. And it's just going to give you the raw information about what's offered within that test, from price to even all of the different details. So let's just even click into one, right? So we'll go to mold and mycotoxins. And again, something that's only going to be found on Rupa Health. If you want to hop into the lab test catalog, you can even hop in and see all the tests that we offer. Uh-oh, looks like my internet. Let me know when I'm back, guys. I'm back. Amazing. Thank you. So what I was saying a moment ago is we even have a lab test comparison tool, really unique, allows you to compare tests from different companies that we partner with. But if you just want to hop in and browse around, you have access to the lab test catalog as well, right? So all the different tests on our platform, very transparently. You can search, you can click into the details, see all the costs associated with them. Again, all the biomarkers are going to be transparent here for you as well. So really anything you need, our goal here at Rupa Health is to be a one-stop shop for you and your lab tests, and really just to make life easier. Whether you decide to, use Rupa exclusively for your lab tests, or even just want to implement it into some components of your lab test. Maybe you find that, hey, I have a better relationship when I order these tests directly from the labs. That works fine as well. So right now with Rupa Health, I see the question about insurance. We do operate primarily only on cash. However, we do allow you to add ICD-10 codes to any order. And then from there, we'll automatically create a super bill to submit that to their insurance for potential reimbursement. So again, we'll automate the super bill process. All you have to do is add those ICD-10 codes to an order, and we'll automatically create a super bill for your patients. What else? We have some cool stuff, y'all. Lab shops. Lab shops is something that's fun, brand new product. But depending on if you want to create a customer or patient-facing experience, we can show basically create a e-commerce side of things. And so you'd be able to say, hey, these are the tests that I offer, put them on your website, and then they'd be able to order them directly from Rupa Health through lab shops. Not for everyone, but it is an option available for you at no additional cost. My biggest recommendation when it comes to Rupa Health is always, since it is free to sign up for, if you are interested, there's no point in not signing up, right? You can always sign up for a platform for free, play around. And if it's something that you like, absolutely. There's no contract in play, right? You're not paying any subscription fee. You're not paying any minimum payment, anything like that. So, hop in, play around. And if it's something that could potentially change your business and make your life a little bit more efficient, that's what we're here to do. So I'm going to hop right into questions, see if there's any questions in the Q&A that came my way. But in the meantime, I'm going to put up my contact information. So if you do have any questions, you can just reach out directly to me. Again, my name is Adrian. My email is just adrian@rupahealth.com. And then here's my phone number. So right now we only unfortunately operate within the US. So we can't work with our practitioners in Canada yet. Trust me, I'm pushing on it. We're doing our best here. New York. So really good question about New York. So Again, similarly, we are working on it. Actually, there is a very much so clear path to be able to allow us to operate within New York. So right now, New York, New Jersey, and Rhode Island are the three states that we do have limited ability in to service patients. And so we actually are working on that. Is there a draw fee? So Flora, great question. The draw fee when it comes to tests that require a phlebotomy will vary based on the lab. So what will happen is if you are ordering a test that requires a blood draw, we'll go ahead and send all of the necessary resources over to the patients for them to be able to schedule that blood draw. Now, we do work with a handful of blood labs, everything from Access to BioReference. So we're actually in the process of onboarding Quest and LabCorp, which is really exciting. So long story short, the answer there is it depends. With the Quest and LabCorp, there probably won't be one, but if you're using maybe a specialty blood lab, there is potential for that, but we'll always be transparent about any additional costs that are applied to your patients. Shows the cell science tests he recommends again. Yeah, so I can actually share the slides out. That'll be more in the slides. What I was showing here was just in my favorites. So an easy way to find all of the cell science tests is simple. So if you just go to the lab catalog, I can go by filter by lab company, head over to cell science systems, and I can see all of the tests. So I can hop over to the CMA that we were talking about today, see that it's $199, click into the details, and I can see all of the different details, including patient collection instructions. I can view a sample report here and see everything that it's testing for within the biomarkers. And what's going to be really nice as well, when this is uploaded into the Rupa University. So if I hop back into learn about labs, right, I have all the different lab classes that we've done, all the live classes, and I click into here. If I click into, let's say, this previous one that we've done with Dr. Silverman, I can scroll down and I can see all the different categories, and I can click into these different categories. It will bring up all the information within the immune system and all the relevant learning materials as well. So we're really building this out to be more than just, hey, here's a single live class. We will show you the relevant information about the specific topics within that live class as well. So really unique, and I'm super excited to really see what the future of Rupa Health looks like, even 6 months down the line. How do you set up an account with Rupa Health? CME available? Not yet, Jeff. Hopefully, excuse me, Dr. Bark. Not yet. It's something that we're working on. I think one of the biggest things that we need to really weigh when it comes to CME is that we love our labs. And of course, as you know, we can't necessarily mention the names of the tests or labs or have them sponsor the content when we're doing this. And we really love being able to give our labs and our partners the platform to be able to present the value of their products. And so CME, I can absolutely see it down the line. However, right now, we're really focused on presenting and creating these live classes. How do you set up a Rupa Health account? So all you're going to do is go to rupahealth.com and sign up for free. I'm more than happy to set up a call with you. Again, Adrian@rupahealth.com, and you'll be able to set up some time directly with me as well. I'm more than happy to do a more kind of detailed deep dive into your business. These ones at the end of the live classes tend to be pretty high level overview, but if you have more specific questions about how Rupa can benefit your business or really work in your existing operations, more than happy to. Is this accessible to non-physicians? It is. So I mentioned a moment ago, we do have a program called Physician Services. And what that will do is allow you to be able to partner with a licensed physician who would be able to place orders for your patients on your behalf once you make the recommendation. I had the same question about comparing NutriVal, patient order directly. So you do need to be a licensed physician to order tests through Rupa Health. Now we do the physician services program. However, patients cannot order testing directly through Rupa Health. I'm loving the questions, y'all. Keep them coming. How does testing to the NutriVal go through Genova? I'm not sure, Chet or Dr. Laskowski, if I understand your question. How does this testing to the NutriVal through Genova? RDNs, yeah. So anyone can order. So here's let me give you kind of like a more detailed explanation of how testing, what we call ordering rights or ordering access, works. Anyone is able to create a Rupa Health account, right? Period. However, your ability to order testing directly from a lab depends on your license type. Now, there's a lot of nuance to those license types, right? For example, A naturopath in California has full access to order any test, whereas a naturopath in Florida isn't licensed, right? And so your license type has a role in it, but also the state in which you're licensed plays a major role in it. And so the way that I kind of simplify that is if your license allows you to order from the lab directly, then you're able to order that test through Rupa Health. However, if your license limits that ability, that's why we have the physician services program available as a supplement. Oh, gotcha. So the next question is, how does the test compare? That's not something I'm honestly going to answer. I'm not qualified to answer that question, to be honest with you. So, if that's something that you do want to dive into, I'm more than happy to provide the educational resources that would allow you to get that answer. Myself, I am not a practitioner, so I'm not going to dive into that. You have a sample test that we can share. Yeah, absolutely. Comparison test or a comparison feature would work. That's exactly what it's there for. There is a fee for using physician services. It's $25 per kit. So a kit would be considered an individual test. However, let's say that you're creating a blood panel and maybe you're testing for a number of different biomarkers in that blood panel from a single blood lab, then that would also be considered one kit. So you can combine those, but however, one test would be what we would consider per kit. But yeah, the comparison tool would absolutely work. And you can customize the comparison tool as well. You don't have to use our preset ones. You can add different tests into it and customize the comparison tool however you'd like. Can you select the physician service? You cannot. Can you select the physician you work if you have the service? Francis, I'm not sure if I fully understand that one. Can you select the physician you work if you... Correct. So the 7% is on total charges. So it'd be $25 plus the cost of whatever test you're ordering, and then 7% on top of that. Y'all, these are amazing questions. Keep them coming if you have any more. I'm free for the next 6 minutes. So got it. So choose the physician you're working with. Yeah, I thought that maybe. So no. So you can't select the physician that you're working with. We partner with an organization called Open Loop. And so they're the ones that provide the physicians that we use for physician services. And so there's no selecting of a physician. However, if you are in a position where you have a practitioner who is licensed, let's say you have a physician and they're comfortable, maybe you partner with them or work with them, and they are comfortable with you ordering using their license, which, it can be case by case, depending on how your operation is set up, you are able to add them onto an account. What's really cool about Rupa is, it's not just designed for solo practitioners. You can set things up in a clinic setting where you can invite multiple practitioners, admin, staff. Everybody will have their own separate logins. But let's say if you're a staff member and want to be able to order a test for your practitioner, you do have the ability to do that. Why is it called Rupa? Yeah, this is a fun question. So Rupa is the name derived from a nickname from our CEO, from her mom. So that's the story behind Rupa Health. Her mom has a unique and directly correlated with functional medicine health story and health journey. Not my story to tell, but that is the context behind We Are Rupa Health. Yeah, Francis, absolutely. And Francis, also, if you want to reach out to me directly, and we can have a call, more than happy to hop on a call or set up a Zoom and we can kind of talk about how other practitioners have leveraged and set up similar type accounts with Rupa Health. As a nutritionist, I will need to use physician services. Yes, perfect. There are so many labs and options. How do you determine which are the best? What process do you recommend to determine? Yeah, super good question. And honestly, the question was, if you can't see it, was where do you even start, right? There's 30,000 different tests on Rupa Health. How do you know where to start? That's why we create this education, honestly. I think it depends on the practitioner. It depends on the circumstance. It depends on the patients that you're trying to treat. But using all the different tools that we have in place really does make things a bit simpler. And so kind of let me show you and run you through that scenario. So if I'm in the lab test catalog itself, we have a number of different ways. So again, it depends on what you're looking to do, right? Am I looking for the most popular test? I'm looking for the most comprehensive tests. Am I limited by cost, right? So there's a ton of different variables to consider. But one of the things that we do just right off the bat is this is a ranking by most commonly ordered tests, right? So you can see the most commonly ordered tests on Rupa Health right off the bat. Beyond that, if I want to dive a little bit deeper and see exactly, hey, what are these tests and how do they compare to each other, right? That's where I can do things like building that lab test comparison tool, right? So I can dive into that. Now, beyond that, saying, hey, what is the best test for me? How do I interpret this test? What do I, where do I even start? That's where the learn about labs comes into play. And so we want to be kind of along the ride with you step by step. And so if I want to hop in, I have not just webinars like we're on right now, but I also have access to a magazine, right? So if I want to hop in and visit the magazine, hop in here, I can even do a search for the GI map, right? Let's see what comes up. And here we go. We have a GI map interpretation 101. Right. So there's a lot of different resources available for you, and understanding just how kind of even overwhelming it can be with these tests. We want to be able to provide as many resources as we can. Now, that being said, legally, we can't provide you medical advice, right? That's just the legality of it. However, what we can do is put you in a position to give you the resources necessary to make the choice that's best for you, for your business, for your patients. Yeah, so Julie, we're still kind of ironing out the coupon information. I can tell you kind of what that looks like. I will email out the details of along with the recording, so keep an eye out for that next week. But what it's looking like is for new practitioners ordering the tests, we'll get 50% off. Now, again, still have to iron out the exact details of it, what they'll look like, and we will be sure to send out that information on that. RDNs, yes, again, RDNs, it does depend on license and lab type and all that. You should be able to order some testing. However, again, it's just going to be dependent on all those fun nuances that the medical industry likes to place on licenses and all that. Let's see here. As nutritionist, Bay Area. What's up, Francis? San Francisco, nice and rainy out right now today. Seems that by opening this webinar to everyone, including them, patients will end up driving physicians to sign up with your platform so we can drive benefits for your service. Yeah, I think, Joe, that's a pretty fair assessment, right? Our mission at Rupa Health is to help bring functional medicine to the world. One of the things that we see more commonly, or very commonly, is patients coming to us looking for practitioners, not knowing where to start. Medicine is and should be personalized. Functional medicine is growing at such a rate because I think people are just tired of going to their general practitioner and not feeling their best. By no means is it we're out there to try and take over the world, but we want to be able to go out there and provide a service that's going to benefit and make these tests more accessible to everyone. Because at the end of the day, I think that everybody, and this is just me personally, I'm not speaking for the organization, I think everybody should have access to these tests because it's important to know your numbers. It's important to know a treatment plan and how you can better yourself. So yeah, I mean, that really is the goal, is to help bring functional medicine to the world. Can you have more than one provider and practice share the same Rupa Health account? You can. You can have your own separate logins and it'll all be on the same dashboard. Perfect. I appreciate you all so much. This is actually making me really happy. Did you give the coupon code information yet? No, not yet. Again, I'll email all that information out. I got to jump, y'all. But hey, thank you so much for your time. We do these webinars every single week. So we look forward to seeing you then. Again, if you have any questions, here's my contact information. It's just adrian@rupahealth.com. We've got, I think the next 3 or 4 months is completely filled up. So every single week, we're going to be doing these with different labs. Cell Sciences is probably going to come back and do a different talk. We love our partners. But this is what we're here for, y'all. Feel free to reach out again with any questions that you do have. Thank you so much and enjoy the rest of your Wednesday. We'll talk soon.